Okay, hi everyone. Thank you very much for coming today. So yeah, I'm Lucy. I'm going to talk about my journey towards a PhD, which funnily enough was inspired by Jo, who is here from last year. So Jo is from Stanmore, and following a conversation with her last year, I thought, right, I need to actually go on and do something with my research side of my career. So thank you to Jo. So I'm going to talk to you a little bit about what I've been up to over the last over my career, but also over the last 6 months. I'm just going to start with the pillars of advanced practice, because I think that's really what prompted it for me. So the pillars for advanced practice are, number one for me and probably a lot of people, is clinical, and we're all really strong at our clinical. It's really the essence of what we do. It's often why we're in the roles that we're in. And I've been here for 23 years, mainly in orthopaedics and MSK, so I think my clinical is really strong. I did an MSc in 2014, which was the clinical masters at Birmingham. I'm an MACP tutor, so I do placements for people training on the MACP programme, and I also lead on the young adult hip service here at the hospital. So we have trainees and we do clinical practice with them, and they kind of join clinics with us. And we also have a young adult hip centre here at Birmingham, which actually is the largest in the UK, and I've been working within that for the last 13 years. So clinically, I've kind of got to the point where I feel pretty happy. It's probably my comfortable zone. And then the next pillar is education, which really fits very much into clinical, because if you're happy with what you're practicing, you end up being very happy to teach about it. So I do lots of kind of presentations locally, regionally to our referrers, nationally at conferences. So last year I did the British Orthopaedic Association conference, the British Hip Society, and a few others, and also some international work as well. So it feels like my field's expanding, and education kind of is up there really with the clinical for me. I also lecture at the university on the training programme, and I was very fortunate to get the British Hip Society non-surgical travelling fellowship in 2023. So I travelled around the UK and visited all the young adult hip centres, really to inform the clinical part of my role and to understand what was happening at other centres and to bring some of that education back. So the education side is also pretty good for me, and I'm fairly happy. And then I move on to leadership, and again I'm pretty happy with leadership generally. Lead the peripheral advanced practice team here. I'm a lead on the hip network. We set up this UK hip network, which is now kind of across the country and links up all the physios who specialise in young adult hips at all the large centres. So I founded that with Stanmore and Exeter, and I lead on that, and we run meetings every 3 months. I'm also linked in with the British Hip Society. We do some international work through them. Also a lead editor on the Ortho Pathway project, which is across BSOL, and that's looking at creating a digital support tool for hips and referring hips into our service. And that's also led to some work on GIRFT. But the reason I've got a slightly wobbly face is that I can lead and I can teach, but I don't really have anything of my own to teach about. And it started to bother me over the last 5 years, where I feel like I need to produce something new and novel to add to my area. And then that leads on to research, where it goes all a bit wonky. And that's not because of a lack of experience and involvement in research, but these things I've been doing for a long time, and research I only really got involved in probably about 10 years ago. And so for me, research is always lagging a little bit behind. And I think there's an element of that being because it's not really strong in our undergraduate education. And it's also, for me, wasn't really strong when I was training as a physio, as a band 5 and a band 6, because we're so busy trying to become stronger clinically. So I always feel I'm a bit behind, and I've done quite a lot here. Gareth knows I've worked with Gareth for a fair while, and I've run my own study, which I published. I've been a PI on other studies. I delivered the fashion study, which was a hip study across the UK. I also supervise dissertations, I peer review, I'm a trustee on a research charity. And here I did a master's to doctorate bridging programme in 2018 to kind of gear myself up to the next stage. But even so, I always feel slightly worried about research and slightly out of my depth, and I don't feel like I have mastery of it in order to complement all the other pillars. So that's kind of where I had got to this time last year. And so then I thought, well, where do I want to be? I really want to use the experience I've got to ask the right questions. I want to be able to use it to shape research design and to deliver research here. We're a national centre. We, one of the largest for young adult hip, so we should be delivering research. And I want to contribute new information to the area, so I'm not just talking about other people's work. And then that leads into teaching and leading. And then I look at the role models out there for us, and there are people. There's Professor Caroline Alexander in London, and she was a bit of a trailblazer and has been a clinical academic for quite a while, and has started to get that momentum up kind of locally in her centre. And then another one locally is Caroline Miller, who's at the University of Birmingham and UHB, and she's probably about 5 or 6 years ahead of me. She's a consultant physio. She's very clinical, and I think that's really important for me, is that you stay clinical and you do your research alongside your clinical work, so you're informed by your patients. So those are my role models that I look to. And then I started to think about, well, what are the barriers to me? And there was this study published in 2023 which talk about limited time, mentorship and funding opportunities compared to our medical counterparts. And I think we really feel that. It's really a really strong part of the surgeons here and the medics that they do research as part of their normal practice. But for us as AHPs and for nurses, it's not as strong and it's not as valued as well, is my feeling. The mentorship I've highlighted because whilst you can have time brought out to do research and there's funding to support that time, if you don't have someone guiding you, and I've experienced this, you can just go round and round in circles, not knowing kind of where to go, if you're doing the right thing, if you're wasting your time. And I think the mentorship is really key. And we also know that there's been a historical focus and funding structures that have prioritised medicine, and our publication rates for AHPs is really low at dissertation level, so about 27% get published. So I think there's something really important in that we really encourage those pieces of work to become published so we can add to the literature. And that's just a table really to compare the two, which does show that for AHPs, there needs to be a culture change to enhance us contributing to research. Okay, so why should we? We know that research active trusts have better outcomes. We know there's lower mortality and higher patient satisfaction. So it seems obvious that we do more research. And from a clinician point of view, I very much feel if we're research active, it will improve our staff recruitment. You'll attract people who want to be clinical academics, and a centre like here and all the other big orthopaedic centres, that's what we should be doing. And we also know that it will improve retention because actually people can see a career pathway that they can stick to. So for someone like Susanna, who's kind of starting out and doing her PhD, we want to keep Susanna and offer opportunities for the future so that the career is here. So I think those are really good reasons why we should. It also fits with the caseload we see. We have over 20 million people in the UK living with MSK conditions. We only operate on a small proportion of those. So actually, we don't need doctors seeing the large proportion of those that present to hospitals and primary care. We need AHPs and nurses to be seeing those. So we really need to invest in clinical academia in those areas. And it also fits into our strategy. We need it to be patient-centred, and here in the expertise we need to be looking, you probably can't read it, but it says by 2028 we will have increased our influence at the leading centre for orthopaedic surgery and MSK care through cutting-edge research and the MSK Academy. And so it fits that we need to enhance this group of our staff to contribute to that. Okay, so how are we going to do it? And this was published in 2022, and it's the AHP Research and Innovation Strategy, and it talks about all these areas, so capacity, capability, context and culture, and we need to engage that really in our departments across all our areas to try and encourage it. So for me, it was looking at how am I going to fit research into my role, how am I going to deliver it, and how am I going to make sure that I continue doing it and then inspire anyone else to do it as well. So So what I did was, after talking to Joe and then kind of last year thinking about what I wanted to do, I applied for a pre-application support fund from the NIHR, which was brilliant actually. I was successful in getting it in November and it kicked off in January. I had to use it between January and March, and it was to develop a PhD proposal. And they very much want to focus on these, the 3 Ps. So the person, I felt like I was the right person in terms of my skills in hips. The place, we're a national orthopaedic centre. We want to be at the cutting edge of research and we lead on young adult hips. And the project, so the project for me was really to look at hip dysplasia, which is a condition that affects young people, and it's a condition that affects the shape of the bone in the hip and means that often people get pain and it can lead to early arthritis. There's limited evidence for physio interventions into it, and I wanted to look at whether we can develop a new intervention to help treat this patient group. We have good surgical options, and when I see people in clinic I feel like I can't offer them much more than general physio, and I know those general physios don't know a huge amount because there isn't the research to support their decision making. So the funding obviously was for kind of January to April, and so my goals within it were to look at what patients wanted, so PPIE, which is about public patient inclusivity and engagement, and I wanted to find out what our patients want from conservative treatment and use that to shape what I was designing. I wanted also to do some training on complex interventions so that I felt like I knew what I was including in my proposal. It was also to identify an academic supervisor in a higher education institution to support me because I really needed that mentorship, and part of the application is you need that support. I had to identify a clinical supervisor, mentors, and create a project plan. So the PPIE we did here for the one group. So we had 2 groups. One was a group of patients from the ROH who'd got hip dysplasia, and we identified through our service where we felt that they would offer really good perspectives of conservative care. So we had this group, some photos of, we ran in the seminar room next door, and we basically discussed my project and they fed back about their experiences and what they felt was really important. And then I also ran a national group where we advertised on a Facebook page for people with dysplasia, and we ran an online similar group with 8 participants and had the same kind of questions but got a national picture of what people wanted. And we reimbursed them, so part of the funding helped to reimburse participants using the Involve guidance, which is on the NIHR website, and you can all look at that if you're interested. And that was really important because then it felt like you were really valuing the patient's time, and they felt that they were really important part of the project, which they are. And most of them are going to continue to be involved and input into the project development, so you're kind of engaging an ongoing dialogue with patients. So how did it help? Well, we met patients. Hayley from research helped me to coordinate the sessions and facilitate it. We understood their story. We kind of documented it all. We had quotes from what they were telling us. But for me, the biggest thing was I found out what was important to them versus what I thought was important to them, which was actually very different. So I thought, oh, we need to create some amazing physio intervention for this group. And they said, physio is a drop in the ocean to my conservative care. Physio is a tiny thing that happens for a few weeks at a time, and the rest of the time I'm left trying to live with this condition. I don't know where to go to for help. I don't know what benefits I can get. I don't know what to tell my employer. I need some psychological support with accepting my diagnosis. So there were all these other things that patients wanted, and I was focused right in on the physio. So it was brilliant because it completely changed this view of what I needed to be kind of looking at. So for anyone out there who's got a patient group in mind, some PPIE work is great and probably is a really good starting point for research. And so this kind of feeds into the strategy again. So again, about it making it patient-centred. I wouldn't have known that if I hadn't done the PPIE groups, and so I would never achieve this patient-centred care if I hadn't gone down that route. And that's like one tiny group of the patients that we see. And then it leads into this about making it cutting-edge research, because it can't be cutting-edge if it's not patient-centred. So where am I now? So I've completed the PPIE work. I've done my training on complex interventions. I've done some other training as well, some other work on strength and conditioning, which is a kind of an evolving area of physio where we all kind of need to move forwards with, and some other work on PPI. I've established a network, so I've got a supervisor at Warwick, I've got 3 mentors, so and that's the good thing about mentors. I've got 3 that kind of are involved with NIHR work but also have done PhDs, and so you kind of have develop a network of people who can offer you different skills. So that's been a really useful thing for me. And I'm hoping to apply in October for the NIHR Doctoral Fellowship, which is a 3-year full-time PhD. So that is my plan. So what have I learned? So I think this whole process has made me realise we need to start developing research early in people's careers. If we don't start growing it at the very start, it takes decades to catch up. And some people never catch up and never get on that bandwagon. And we're missing out because we've got all that clinical experience that could inform research. We need to encourage clinical curiosity to address issues rather than just accepting that that's what we do. And I think that's a really good thing for our teams to start asking those questions. I think as managers we need to talent spot and guide clinicians, so anyone who's interested we really need to harness and bring them on board and get them involved in, even if it's, you know, a doctor's project, but they could start doing some work, you know, towards it. Anything to get people involved in the research journey is really useful. But I think this is really key because if we don't talent spot we're missing out. We need to create clinical academic pathways, so once you've done a body of work that you can signpost people to the next body of work to keep them engaged. The worst is to kind of stop and start and then maybe never start again. Match clinical need with AHPs and nurses. I think we need to look at the conditions that we're seeing and the proportion of nurses and AHPs seeing those patients and really look at how we improve the funding towards those groups because those are our biggest groups. Sorry, I'm losing my voice. I'm nearly done. And then running PPIE groups, which obviously I've mentioned. So I think the other things just to mention is that the NIHR is a great resource, and if you haven't looked at their website and looked at those, it's a really brilliant place to look, and there's lots of funding opportunities. I think the other thing I'd say is create a network really early on to help kind of keep driving those research discussions, because I think having really good people around you is probably the most useful thing. And seek out opportunities and take them wherever you can, because there isn't a linear path to these kind of clinical academic careers, and I think we have to kind of, you know, take any opportunities we can to move forward. And that's it. Thank you.